All right, the next presentation is by Dr. Marc Gottlieb, who's a plastic surgeon in Scottsdale with a special interest in complex wound care, principles of wound healing and treatment of complex wounds.
Hi, good morning. When I got this presentation, this is what I received: principles of wound healing and treatment of complex wounds, and I had 10 minutes to do it. So I thought if we can do that in 10 minutes, we can take a few more blocks of time, 10 minutes, and turn you all into cardiologists, vascular surgeons, get you certified. And of course, that's not possible. So I had to pick a point of view, and the point of view is the fact that I'm speaking to a crowd of vascular doctors, and so that means you're all very much involved with wounds. You're all doing procedures to prevent wounds or cure wounds that are there, and some of you may actually be involved in direct wound care. And so you're very familiar with that group of wounds, but the point I wanted to make today is that there are many other types of wounds, and how we approach them to get them healed depends upon a diagnosis. And the vascular wounds have commonality with other wounds, and there's some crucial differences. Let's start with the vascular wounds. On the left-hand side, you see a patient who is of European ancestry, hyperlipidemia, hypertension, smoker, the classic thing where you expect large vessel central atherosclerosis. He presented with a blue toe, and all he needed to do, if anybody had taken his history, they would realize that he has the classic symptoms of Leriche syndrome. So he needed an aortobifemoral or an endograft aortobifemoral or biiliac. Either way, he would have had a great result, but instead, they amputated his blue toe, and there was progressive necrosis, then more amputation, then more necrosis, then more amputation. When I inherited him, he had already had an AK, and that was already necrotic. So it highlights two things, or several things. One is that there are a lot of doctors out there, not vascular surgeons, of course, but doctors who are unfamiliar with what these symptoms mean and the risks of wound pathergy. When you have some sort of injury or intervention and there's unexpected necrosis or infarcts or ulceration, that's wound pathergy. And all these diseases are at risk for that. So you want to be judicious in how you approach it until you correct the underlying problem. Arterial diseases have two distinctive issues when it comes to dealing with the wounds. One is that these are non-pathological wounds. They are, when they have wounds, certainly due to an underlying pathology, but the basic machinery of wound healing itself is completely healthy. They're just being deprived of blood flow. So once the blood flow is restored, they heal. The other thing that's interesting about the arteriopathies is the special risk for infection. With no blood flow, you can get genuine infections, and these are the patients who present with potentially life-threatening or limb-threatening sepsis and the need for urgent amputation. All the other diagnoses that cause chronic wounds can make your life miserable, but they do not put you at risk for loss of limb or loss of life. It's just misery, but no loss of limb. So the vascular diseases get special attention for these several reasons, but there's a whole other side to wounds that involves other diagnoses, and I'd like to show you how to differentiate them. In the middle column, you see some foot wounds where there was a vascular embolus, and you look at the periphery of the wound, it's been debrided, there's no further necrosis, there's granulation tissue, you can see the incision over the ankle where a bypass was done. So this foot is revascularized, and the wound is now healing because it's an inherently healthy wound, aside from the fact that it wasn't getting circulation. Also, there's a lot of text on these slides, and I don't expect you to read it all. I have a website where I post presentations. I'll give you the address at the end, so you can go back and read it at your leisure. I'm going to try to do this in 10 minutes to discuss all the other wounds. Now, imagine this scenario. Patient goes into the doctor, young man says, I have chest pain, and the doctor says, how long? And he says, well, it's been a while, but I'm busy at work, had trouble finding an appointment. And then he turns to his TV nurse and says, quick, prepare for surgery, he needs an emergency heart bypass. Now, we all know how utterly ridiculous that sounds, but look at this from my perspective in my practice when patients walk into my office and they tell me the stories about their previous appointments at other doctors. Substitute chest pain for a wound, and then substitute heart bypass for the other interventions you see at the bottom of that column, antibiotics, hyperbarics, amputations, wet to dry, all these crazy things that have nothing to do with wound care and not germane to what's going on with that patient. They're misleading, they cause further damage, And of course, the silly one is when a young person comes in with a wound and they have completely normal pulses in their foot, and their doctor tells me you need an emergency Doppler to check your arteries. The problem is that there's just no comprehension about wounds because it is an orphan subject. It is not taught in medical schools. I mean, we're dealing with a cadre of people here who have some familiarity with it, but it's not well taught in schools. And even among doctors who deal a lot with it, it's like the blind man and the elephant. In different specialties, you see a side of wounds that are unique to your situation, but not everyone has them, or not everyone has that general knowledge. First important point is that wounds do have a body of knowledge that's founded in the basic sciences about wound anatomy, physiology, pathology, and how to approach them. On the left-hand side, you see a completely normal, healthy wound, and that means it's going to close by natural contraction. On the right-hand side, you see a sick wound that won't close. The histology reveals why. Along the bottom are various other wounds where the histology shows wounds which simply cannot heal unless you do extraordinary interventions because they're infiltrated with lymphocytes and plasmacytes. The concept of a cap wound, chronic and pathological, are these wounds which are due to some disease of the stroma or soft tissues that prevents normal wound healing. When we think about the complex aspect of wounds, first thing is they're trauma wounds, which are benign, simple wounds. They're not complex by any definition of wound healing biology. The patient care, the associated trauma may be complex, but once you get that under control, the wounds are going to heal. Then we have wounds which are not pathological, but still are problem wounds. And these are due to various things like vascular disease, where the wounds are deprived of something, and so you have to do care to restore what's wrong, what caused the wound, but once you do, wound healing is normal. And then the third group are the pathological wounds, those in which there is something fundamentally wrong with the biology of wound healing. And no matter how good circulation is, you cannot get them to heal without doing something special. And the key thing is you have to diagnose what's wrong. Why did they get these wounds in the first place? And establishing that diagnosis becomes quintessential to establishing the right care. And pathological wounds are usually due to something related to ischemia and arteriopathy or to autoimmunity and inflammation. When we talk about complexity, it can mean several things based on context. Anatomical complexity, even though wound healing is normal, that needs flaps, classic or conventional plastic surgery to get closed. It can be physiological complexity. It can be the complexity of multifactorial disease. So you have to parse down what's really going on in the wound. Then you need a program when it comes to treatment, a program of basic wound care that will get the wound under control, keep it from having progressive ulceration, and then you can proceed with your diagnosis. Hygiene, debridement, topicals, edema control. Let's get to this part. Let's look at these wounds by diagnostic category. For the arterial diseases, they're subject to the risk of pathergy. You want to be judicious in what you do until you correct the underlying problem, and the quintessential therapy for them is revascularization. Then we deal with another major group of chronic wounds, the hypercoagulable and microocclusive disorders. They have the same principles, the same risks of care, except that to correct their fundamental problem, they need to be anticoagulated with warfarin or heparins. The direct thrombin inhibitors don't really work quite so well as warfarin does. Then for the big category of the autoimmune and inflammatory disorders which cause non-healing wounds, these wounds simply will not heal because of the lymphocyte proliferation in the wounds. And you have to treat the fundamental cause, for them means steroids and anti-immune therapies. And also, the autoimmune diseases are bred by hypercoagulability and other chronic disorders, so you want to find out why they have the autoimmune disorder and treat that as well. Venous disease represents a mixed pathology. Valvular insufficiency and venous hypertension is a part of it, and if you can intervene early to ablate those veins, that's great, but once they get liposclerosis and ulceration, it's a complex mix of bad wound biology, autoimmunity in the wound, venous vasculitis, liposclerosis. You can't just do simple care and expect them all to heal, but compression is the sine qua non of their treatment, and oftentimes things will heal. Diabetes, of course, is a multifactorial disease. It's neuropathy, it's pressure. If they have vascular disease, it's all the more complex. Their mainstay of treatment, of course, is the mechanical offloading, for which the total contact cast has been a miracle. When we get into pressure and other things, we're getting off the track of what is germane to this group. But one thing to note about pressure is a lot of wounds are passed off as pelvic pressure ulcers when in fact they're vascular infarcts due to people who have bifurcation disease or internal iliac artery disease. So you don't want to confuse pressure with pelvic atherosclerosis. Wound care has the 3 phases of care that all other branches of medicine have. Phase number 1 are the mandatory therapies where you get things under control and prevent progressive ulceration and lysis and infarcts, get the wound asymptomatic, arrest the disease. Once you've done that, you can implement discretionary treatments to get the wound closed. And then in the 3rd phase, it's long-term care, because even though you got the wound closed, these were due to underlying chronic diseases, and there's always a risk that something else will happen. And when you do things right, you look at the panel on the right side, all those patients had wounds that had years' worth of misery and failed care, but do the right things, and they all close up very easy. So it's a matter of understanding these principles. This is my website, aramedica.com. Go to the presentations link. You can read the slide at your leisure. There are 3 other presentations there that are applicable to everything you all do: the hypercoagulable disorders, wound pathergy, and the physics and pathology of wounds. Those are like entire textbooks on these subjects, a lot of text, so you can read all about it. And that's the end of my discussion for today. Thank you.